to bust some myths and get folks excited about some of the new possible regulations and field any questions you guys may have. So please feel free to use the chat box. Excuse me, I'm corrected. Please feel free to use the Q&A box to ask any questions during this session. And we are recording. What? And we'll have that available after the end of the session, and we'll make it available to everybody who attended and put it out on social media, but I will email the link to you guys directly for the recording. So please, please, please don't hesitate to ask any questions. Cindy and Dee, how are you today?
Good. Pretty good. How are you?
I think I heard you both at the same time, so that's always a good thing when we can hear the presenters both at the same time, because in that way we know that their audio is working. So I'll say, Cindy, how are you doing today?
Pretty good. How are you?
I'm excited about this session. We got so many questions sent to us ahead of time that I feel like we've got a lot of really, really good content to go over. And Dee, how are you doing today?
Wonderful. How are you?
Marvelous, marvelous. Okay, so I hope everybody's enjoying their summer. I figured I would start the ball rolling with an OT question. Everybody likes to talk about occupational therapy, and there's some confusion surrounding occupational therapy, but I wanted to touch base on this first question, and you guys can decide amongst yourself who's going to answer. They asked me to please bust this myth. If you have a home health aide, you don't need an occupational therapist on the plan of care. Question mark.
Okay, I'll jump in after I just pick myself up off the floor, because I just want to remind folks this is a non-scripted, off-the-cuff, informal conversation, and that question is just a little bit frustrating because it is a myth that does seem to not want to pass on. I have never understood why you would have a home health aide involved with a patient and not at least have an occupational therapy evaluation. If you're putting in an aide, you've clearly identified there's a need for assistance with self-care. And I think we have to kind of shift at times how we view an aide, not simply as a supportive service, but as a part of the interdisciplinary team that, combined with OT input, can provide assistance at a very patient-specific level that can then be progressed over time in collaboration between those two services to ensure that the patient is not becoming more dependent or more reliant on an aide over the course of care. That's sometimes where I'll see it, Sherry, is it seems that we're going to get near the end of the episode. Now we're panicking because the patient has gotten used to the aide, wants the aide, is very concerned about losing the aide, and now we bring in the OT almost as the, aide remover very late in this to come in and say, well, now what are we going to do? When I think very early on, pairing them up can create a more effective aid plan of care and help advance this patient toward their optimal level of function, whether it's getting them back to where they were or strategies so that they don't decline over our care or become more reliant on this service can be extremely beneficial. I would add one other piece to that though, Sherry, is I would say even if you think you should order an aid, that should trigger an OT evaluation, because I think there's been a lot of question. I was on a call yesterday with discussion about what seems to be very low aid utilization in our setting compared to what people would expect and what our ancient history feels like had a whole lot more aid than it does now. I would say even if the patient is refusing the aid, if the clinician believes this would be a valuable part of the plan of care, that should be a trigger for an OT evaluation.
And Cindy, thank you for hearing that question that way, because I initially heard that question as, why am I getting an eval when there's an aid in there? It's not, it does not have to, by regulation, go together.
Correct.
But the way you heard it, I think, was the appropriate way. That if they have the aid, then they don't need the OT. When in fact, I agree with you, they do. Dee, I know you probably have some thoughts on this.
Yeah, I think if you look at from an audit point of view and you look at care plan development, especially for the aide and working on the premise that eventually that aide will no longer be providing care, right? How many times have you gotten to discharge and the only thing the patient is worried about, who is going to watch me now, right? Once the aide is gone. And so OT does a wonderful job really and has the ability to oversee that care plan and develop a very detailed care plan for the aide. And if the patient has any ability to recover any of that function in their self-care, bathing, dressing, hygiene, then they can much more closely monitor it. In my history working with OTs versus nurses developing care plans, I see very detailed care plan development working alongside the OT, where it's just not, they're washing them from, the first visit on the first week that they're ordered to the last visit on the last week. And then you're fielding the question, who's going to wash me now? So I think OT really is a value add and should be considered before we automatically, put aid services in the house, so that we can have a very clear direction about, are we working and just supplementing this person eventually recovering this function, or is this something that they're going to need support from here forever forward, and how are we going to transition that off of the agency and into personal caregiving or a family member, or with use of DME or whatever it is that's going to optimize that patient and that person's their ability to care for themselves after we're no longer there.
Dee,
I
I have a
agree.
compliance. I have a compliance question for you, Dee. Though you're connecting those two in terms of care plan development and follow through. What are your thoughts? Because I know I've seen it in records, and you have as well, about a situation where there's a disconnect. So OT and the aide are in there at the same time. OT goes in, does their thing, now indicates the patient is able to do this activity and discharges them, but the aide is still there doing it for them.
Yeah, well, that's a problem, right? I mean, and so that's why there needs to be a very clear supervision of that aide and that aide care plan. And so when we practice in our silos, and if the aide is automatically assumed under the nurse who may still be providing care, there is not very clear understanding that the person has resumed these activities. So they passively take that bathing, I have someone coming to the spa and doing all this for me when they're technically able to do it themselves. That's where OT needs to have a very clear communication with the nurse and oversee and make modifications to the care plan. OTs can do the supervisory visits, right? In fact, supervisory visits under the COPs, under the skilled professional, they're looking for people that are fully aware and intimately aware of the patient. Well, the OT would be much more intimately aware of their ADL abilities, and I contend, than the nurse, especially if that's part of the OT care plan that originally put the skill in the house, and they were working on ADLs and self-care, bathing, dressing, transfers in the bathroom, toileting, and hygiene. It would make sense that they would have a better concept, and they should be updating that care plan and communicating that to the aide. There may be a period of time where the aide is there much more as a supervisory standby, quote unquote, touching assistant, Cindy, right? But they're not physically doing the tasks that the patient has now been able to do themselves. And that has to be, and that may be a great reason why we're seeing less aid services, or it just may be, another one of the, forgive me, uncensored comments here, or unchecked comments, where we're counting back from the bottom line and some of the costs, that have been, or the reimbursement that's been affected. So the aides are one more service that gets hacked without any real good rationale for why that is.
Well, when I get to the second question that was submitted by the same occupational therapist, I think that we're starting to see this as part of the issue with cutting therapy services and cutting all services, trying to get to that magical profit line. So the next question is, and I quote, "If it's just a toilet transfer that needs work, then physical therapy can address it, and there's really no need for the occupational therapy eval or treatment." And in parentheses, they said, "Is that really all that needs work? Is there an order for home health OT from the referring PT or the referring MD? Please address how it can be assumed that other disciplines can just discharge that eval."
Well, I'm going to say,
Go for it, Dee.
I'm going to say, if there's an order for occupational therapy, then that order should be answered. And unless PT is going to take up and do the toileting and the transferring and the personal hygiene and the and management of the clothing, and they're going to take that over, and listen, transfer is in the bathroom don't belong to OT. They don't. I mean, our heads are not going to blow off our shoulders, PTs, if we cross the bathroom threshold. We can be working on that, just like OTs can be incorporating balance and gait as they get people from the bedroom into the bathroom for self-care, right? So, I mean, it can be fluid. So I would tend to agree. If the order is there, it should be answered by the discipline. However, there are a lot of organizations, you know, either due to staffing or trying to restrict the amount of visits, they will let one discipline assess for another. And as a physical therapist, I would be extremely reticent to take that on and say that I can determine when the skills of an occupational therapist are 100% needed, or a speech language pathologist, right? So if the order comes across, I think the order should at least be answered, right? Or there has to be a very good reason why it's not. Whether the patient absolutely refuses the care, and then that should be clearly documented. But this idea that it can be discharged by another discipline and fall under another discipline, and just assume because a person can get up and down from a chair or the edge of a bed or on and off the floor or in and out of a car, that they can automatically handle the toileting component of transferring and everything that comes with it. I mean, we're not just going, right, Cindy, into the bathroom, just get up and sit down on the toilet. We're actually we're completing a bodily activity, and there's a lot more to it than simply just up and down.
And I would say, Dee, there's also been some bleed over into bathing as well. That, oh, it's just really the getting in and out part. And you know, PT can work on that transfer, and then we've taken care of the problem. I think we've kind of underestimated the amount of effort involved with completing ADLs, like toileting, like the toileting hygiene, like bathing, and we've kind of oversimplified them and said, okay, if we can just do this one element, everything else will be taken care of. I think if it was thoroughly vetted, that truly was the only issue, and there was absolutely no other ADL related things found, and the patient is refusing to have the occupational therapy evaluation as ordered, then I can see that case. But as you said, Dee, I think it's not just that transfer. How are they doing all the other elements of these ADLs? And I've always, and I just wanted to reinforce that, Dee, I've always been uncomfortable with, if the order came through as orders for PT and OT, to hold off on the OT order and let PT decide whether or not that's warranted. I'd be curious to see how PT would feel about that in reverse. If OT was, okay, well, you go first and then you decide whether or not PT is warranted. These are two separate and distinct disciplines. And if they were ordered as such, an evaluation from both really should be completed.
But guys, I'm going to jump in real quick, and I want to jump in with Marcy's question first, but then I have a statement to make about what y'all were just saying, because it's a commonly occurring thing, and I want to thank Monica for these questions, because we're seeing all kinds of machinations going on for changing the amount of therapies that are going into the home, and it's a little bit disturbing, a little bit distressing. But one of the questions that Marcy had about the things you guys were talking about, the aid supervisory visits, is that she thought the nurse was required to perform the supervisory visit if they're still involved in the case. Dee,
You want to take
muted.
that, Dee, since you?
Yeah, sorry, I started talking and I was muted. Yeah, I think that's still where it is, as far as, you know, and I'd have to pull up Chapter 7 to look. In therapy only cases, being a therapist, yes, but that doesn't mean that the OT cannot inform and provide information in the chart about exactly what the care plan is. So maybe the nurse is doing the supervisory visit, right? Whether they're present or not, and they typically will do it like every week if nursing's involved. But that doesn't mean that the care plan modification, if OT is still involved, cannot be generated with their input, right? So this is one of those interdisciplinary things. So forgive me if I misspoke and talked about the supervisory visit. Yes, the nurse, I think we're still in that very siloed approach that these are nursing activities versus these are therapy activities. But the building of the care plan does not have to be done specifically by one discipline, is my understanding. Cindy,
And currently
during
the public health emergency, I just want to let you guys know that we're currently in a moratorium on those 14-day supervisory visits. And that is in the new proposed rule to remain that way. Cindy, were you going to say something?
No, not on this particular topic.
Okay. What I wanted to say about the disciplines acting for one discipline or the other, I think that home health has had a sordid history with this. with allowing when the PT only referral comes and the nurse taking the start of care visit. I think that that's been agency practice for years, but many times when the nurse goes out on that first visit, there's been instances where it's been determined whether or not the patient can tolerate therapy or if they truly need therapy. So I didn't know if you guys had a little bit more to say about that.
So you're referencing situations where it's ordered as therapy only and then nursing is added to that?
No, I'm saying that when a lot of agencies are still in the practice of the nurse doing the start of care OASIS regardless of what the home health order looks like, whether it says therapies or not. And in those cases where they start the case, they oftentimes will make a determination whether that patient truly needs the therapy or if they can tolerate the therapy. I've seen that instance happen where they've actually made that determination for the other therapies on the case. I didn't know how that applied or if it applied to the OT situation, but it seems like it does, and it seems like it's a more long-standing problem.
Well, I think to a certain extent, in unique situations where, regardless of the discipline, you get out to the home and this patient is in really bad shape, and it is very reasonable to think that right now is not the time to add additional services. I don't think there's anything inherently wrong about that. Looking at it and saying, I've often wondered, in some of these patients with a lot of issues going on simultaneously, the whole front loading is a team activity, means we try to ram in multiple nursing visits and the PT and the OT and the aide, everybody from the jump. For some patients, that may not be a good idea. It may be better to get the priority issues of their pills are scattered all over the house and they're medically unstable and they're overwhelmed. All right, then as opposed to, do you want therapy? Or no, I don't think you can have any therapy. Maybe we need to delay the start of therapy just a little bit to get this crisis stuff under control first, and then bring in other disciplines as appropriate. And I'm going to go on a limb on the whole therapy issue and say, I have never understood why this setting is so top heavy, PT over OT. The very nature of the setting we're in, home health. How are we not seeing that tipped the other direction, where there's actually more OT going on than PT, because the home just screams all of these self-care and IADL activities and all these things they have to do that they don't have to do when they're in the hospital, when they're in the skilled nursing facility, all of those strategies. So I've never really understood the 10 PT to 1 OT model, which I think, Sherry, has led to the have PT evaluate for, as Dee touched on, because I don't have any or I don't have enough. And so I'm trying to ration by using another discipline to give me input. So it's a multifaceted issue. I don't necessarily think it's poorly intended in the majority of situations. I think it's a staff availability, patients overwhelmed. Again, I would rather see an overwhelmed patient be offered to start a little bit later than the infamous patient refused and we never ever bring this service up again. It was like a one-time only deal. But I think that it can be misused in certain situations where it's, I'm just going to find every reason I can to not add anything else to control cost.
No, you're absolutely right. And I'm going to call it what it is. It's quote unquote very anemic interdisciplinary care, right? It's like it happened for a different reason, but it could be considered interdisciplinary care, but it lacks some of the things you need with interdisciplinary care. Is that a fair statement?
Right. But what I think is interesting is we don't really ever have these conversations to therapists, because if therapists go out to the home and find anything that feels nursing, we are on the bat phone within seconds to get that referral. I mean, there isn't big decision trees. There's not really think it through hard. There's not, oh my gosh, I've got to get permission from 10 people. If that wound is looking like that, or your pills are over there, or something just does not feel right, bam, I'm going to go get an order. And if they come out and say, everything is really okay, it's been taken care of, there's not a huge need for nursing, well, great interdisciplinary care. I feel better that that person with that training went out and made that decision. I just think some of the practices developing around who gets therapy and for what, We've seen an uptick in that in PDGM. So you can't help but think, is this really about patients, or are we back to trying to figure out how to get out of certain services? And yes, I know there's probably at least one person listening to this going, but we have doctors that click every service we have every time. Okay, I still don't think that's the norm. And I think unless there are very blatant reasons to not follow up with the evaluation from those orders, I think it's a risk to start slicing and dicing and deciding which are relevant on the back end without those professionals getting a chance to evaluate.
That's a great point, and I couldn't find my mute button. I just want to take this moment to remind everybody that if you have a question, to please write it into the Q&A so that Cindy and Dee can address it for you. But I have a great PDGM question that's next, okay? Okay, so from my understanding, the amount predicted to be given with the PDGM model is the amount predicted whether you order skilled nursing alone, PT, and SN, or just PT. I know previous to PDGM, the more PT visits, the more the return. But from my understanding, that doesn't apply anymore. Am I correct? If not, can someone please explain to me what I'm missing?
Well, I think there's still some confusion. Residual from our previous payment model to this idea that there is some sort of therapy dollar and nursing dollar. The previous life we had of therapy visits affecting reimbursement was simply seen from CMS as a patient characteristic, just like their functional status, just like their diagnoses. If the patient needed these services, then this was a mechanism to provide additional reimbursement because it was going to cost an organization more to add these services to the plan. It was never intended to incentivize, motivate, or compensate for therapy services as some sort of add-on or island. When we went to PDGM, now the rumor started initially, and still somewhat exists, that now therapy is somehow not paid for. Or my concern is it paid differently? Are we being paid less for a therapy visit than we are for a nursing visit? No, we're not paid per visit. All visits are right now in PDGM, and all they were ever meant to be was a marker of how many visits did this patient get, regardless of who provided it. Okay. And in PDGM, that is solely to figure out whether or not this is a LUPA case. So there is no therapy money, there is no nursing money, and there is no payment differential because we're not paid by the visit. We're paid for an episode of care. So, the question, Sherry, touches on several things. The residual idea that more therapy got me more money before, maybe I don't want to do that now. Or am I paid differently if it's therapy? We have to break that. The intent of the model is to provide care based on the individual needs of this patient, and we get a fixed dollar amount to be able to figure out how we're going to best manage this individual. But we also have to keep in mind that 30-day payment periods are really no different from the 60-day episodes we used to have, in that they're not to the penny accurate budgets for that particular patient. We're going to win on some, we're going to lose on some. The bottom line is we have to be able to win a few more than we lose to stay in business. And in some of them, this math is crazy and it looks like I got a whole lot of money and this patient doesn't really need this level of care. And others have very little and you're like, look at all this other stuff I need to do. The model is supposed to come out as a whole, not as an individual 30-day payment period budget type idea. So we got to bust the myth that therapy is not paid for. The idea that more is better just for a financial purpose needs to go, but we also can't go the reverse and say, well, the way to make money in PDGM now is to withhold it. Briefly, for the sake of time, Sherry, I just want to add that factors into some of the information that has now come out in the proposed rule for 2022. Table 9 in particular, where CMS looked at the functional levels, what they predicted would happen in PDGM versus what has actually happened. And we see that there are significantly more patients in the high functional impairment category, more than they expected. You overlay that with decreasing therapy use, and it does continue to raise eyebrows of, if your patients do have more functional impairment, then why would your therapy be going down? So we have to be focused on what the patient needs in these situations.
And Cindy, I agree 100%. And the data is going to catch up, guys. The data is going to catch up. I want to refer back to hot off the presses, ding, 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 ding. I want to refer back to the question that Marcy had, and I please make sure I got the name right. Yeah, Marcy, her question about the nurse having to perform the supervisory visit. While we were in the middle of this session, we were hot off the presses with the COPs, and Dee has an update.
Thanks, Sherry. So I went to the updated COPs in 2018, and I looked under the statute 484.80 parenthesis H, and it's supervision of home health aides. And what it says in the interpretive guidelines for the conditions of participation. And so it's you know, it's a little hazy. Weren't my favorite IGs that were ever written in 2018, but it says if the home health aid services are provided to a patient who is receiving skilled nursing, physical or occupational therapy, or speech language pathology services, a registered nurse or other appropriate skilled professional who is familiar with the patient's plan of care, and the written patient care instructions described in the previous statute, 484.80G, must make an on-site visit to the patient's home no less frequently than every 14 days. The home health aide does not have to be present during this visit. Now, that's what I originally said, and typically we defer these to the nurses because they're familiar with them. But when we moved in the COPs to skilled professionals and not a list of these are the duties that a nurse must complete, these are the duties that an aide must complete, these are the duties that a therapist must complete, it expanded that a little bit more. And so going back to that concept, Sherry, about if the OT is integral in the development of the home health aide care plan, it makes sense that they can follow through and they can do the aide supervisory visit if they're still providing care. There is further information in the interpretive guidelines as if an area of concern in aide services is noted, then the supervising individual must make an on-site visit, and typically they see that as a nurse. But once again, when you look at who can be a care manager or a case manager with the new COPs, this also fits within the scope of practice of other skilled professionals, such as your licensed therapist. So I think we need to kind of step away from that and realize what is in the best interest of the patient, what presents, you know, gives us or gives the best information about what we're trying to accomplish with that aide visit, and is going to give the most detailed supervisory visit. And if the OT is integral in that care plan, I would say that the completion of the home health aide visit would fall under that umbrella, as well as maybe not the nurse who might just be going out for a monthly B12, right? That could be extremely different. And so just an aside, we can move on from that, but I refer you back to your conditions of participation, and I apologize for the miscommunication earlier. But still, this goes to that interdisciplinary care planning in its intent, not just in, you know, in theory, but in intent. If we have OTs in the house and they are working on this personal care and getting a person back to some prior level or stabilizing their function as they are now able to do their ADLs, it makes sense, since that is exactly in their discipline-specific care plan, that they are integral in developing and overseeing and commenting and updating on that home health aide care plan.
Thank you so much. In a nutshell, it does not have to be the nurse. It should be somebody integrally involved in their care and very aware of the patient. And it has to be, it cannot be an assistant, cannot be an LPN, a PTA, or an OTA, correct?
Mm-hmm. Correct. And
okay.
And like I said, I think I said that someone who's intimately familiar, or, you know, and so it makes sense. A lot of times the person that goes out, the nurses change and they may not be as intimately familiar, but you may have one OT providing care to this patient the whole time. It seems to me that the burden of familiarity with the patient would err on the side of being the OT in that situation versus the fourth or fifth or sixth nurse that might be going out to see them.
And for those of you that are interested, and I hope everyone is, this is one of the things that is proposed on the proposed rule for 2022, whether or not to make this public health emergency adjustment permanent or not. So if you have nothing else that you want to talk to CMS about, but you feel strongly that those 14-day supervisory visits do not need to come back, please write a letter and have folks write letters about what a burden those 14-day supervisory visits are, and how your agency will be so good about making sure that your aides are compliant and in alignment with their plan of care and their education level. So please make sure you make that comment. I think the deadline for that comment is August 27th. So there's 3 ways you can do it, and if you follow our newsletter, you'll definitely hear about it once in a while about the comment period. So please take advantage of that. Okay, next on the hit list, we have a coding related question. Has anyone heard that there is an industry shift to coding only comorbidities and diagnoses that are addressed on the plan of care? Or should we continue to code all active diagnoses, regardless if they are addressed in the plan of care or not? We are a hospital-based agency and have a long list of active diagnoses that may or may not be pertinent to the episode of care.
So, I'm going to jump in on this because I think this is a really timely question. And we're starting to see with the return of audits now that primary and comorbidity coding, comorbidity adjustments exist in primary diagnosis group assignment, that there's greater audits being done on issues related to coding that we've ever seen historically, right? So in these audits, what I've heard from some of my colleagues on the audit side of the aisle is that the auditing entity, the ADR, let's say it's coming from the Medicare administrative contractor, is referencing the OASIS guidance manual in relationship to primary diagnosis group assignment. That's the M1021, and for comorbidity adjustments, the M1023 guidance that you find in the manual. So the first thing I would say is read what the guidance manual says is and is not appropriate to include as comorbid diagnoses. And many times what you'll find is this also refers you to what every credentialed coder understands is the official coding and reporting guidelines that come out yearly with the updated code set. And that they do updates in April, but they primarily do the major code set update in October 1st of every year. And so what we know and what I teach and what we talk about extensively is what is a secondary or comorbid diagnosis. And there's a very clear definition of that comes from the UAHHP, I don't know, anyway, it's the hospital-based language for diagnosis coding. And what it says about comorbid diagnoses, sorry, Sherry, I didn't have the chance to pull up my official coding and reporting guidelines book as I'm shuffling through my desk looking for it. There it is over there, because we're in the
we're live.
calendar year
We're
2021.
Live. This is live. You get a break.
And what it says about secondary diagnoses, and I'm paraphrasing as I'm looking through the book, is that every code selection of secondary diagnoses, every code that either is actively treated, right? Actively involved, which means it can be treated, monitored, or it's receiving intervention, or it has the capacity, if it's well managed, to impact the plan of care, should be included as a relevant secondary or comorbid diagnosis. So let me say that again. Any comorbid or secondary diagnosis, i.e. not the one that is receiving the greatest acuity or services or is driving the plan of care, the reason for the referral, that's your primary. It is these codes that are either receiving active treatment or have the ability by simply the nature of existing that they can impact the plan of care, even if they're not receiving active care, which is monitoring, okay, or treatment, intervention, testing, whatever. Okay, so let me give you a perfect example of that. All right, a perfect example will be a patient who has diabetes, right? Who may have had a surgery and has a wound that is healing. And this person is on a anti-diabetic medication with or without insulin, whatever. And maybe it's a therapy only diagnosis. I'm going to try to keep this clean and easy for you. All right, because none of it is clean and easy when we get to coding. But should diabetes should that be included in the plan of care? And my answer to you, not just as a therapist practicing at the top of my license, but as a credentialed coder and a coding instructor, is that diabetes should be included. It's not driving care, the aftercare for the resolving the repair of the fracture or whatever is. But if that diabetes is not well managed, and the patient is doing it all themselves, right? They take their insulin, they monitor their blood sugar, they're under the care of an endocrinologist, boom, 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 boom. They know their medications. Great, 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 great. If that goes awry, are they going to have good healing? Is there complications that could arise? Is there things that could impact the plan of care and the normal healing process of that surgical wound? The answer is absolutely yes. And so diabetes should be included. So what we see now is this, Cindy, you can jump in if you want, this mad array of all this diabetic education that that therapists say, whoa, 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 I'm not familiar with, right? I'm not going to do all this stuff. Okay. Therapist, I ask you this, when you go in to see the patient, do you ask them if they've taken their medication? Do you ask them what their blood sugar was? Do you look at their monitor and do you make sure that they are homeostatically sound to participate in therapy that day? Do you do that? If the answer is yes, then you are monitoring that comorbidity and making sure that it is within the parameters that are acceptable. What if you treat somebody who hasn't eaten and all of a sudden they get lightheaded, dizzy, you don't know what's happening? Are you going to go ask somebody or see about checking their blood sugar? Are you going to advise that maybe they take some orange juice or something? Are you? Yes, of course you are, because they can no longer participate. It could become an emergent situation if they become hypoglycemic. And so this idea that there has to be, that we're building a plan of care and we're only putting the comorbidities that we're going to treat on it, no, we have to build a plan of care that is comprehensive and meets the needs of the patient, and then pick those interventions that are appropriate. We will monitor blood sugar parameters during the delivery of services. We will make sure that blood sugar values remain within normal ranges so that we can see the normal healing process of that surgical wound. That is a perfect way to explain secondary comorbidities. But what we see in quality and in other people is that we have an EMR that now throws 10, 12, 15, right, Cindy? All these diabetic training and education that causes what we call a therapist's pushback from it. And in reality, the EMR should not be driving care plan development. The clinician should be driving care plan development based on the presentation of the patient. Long answer to that short question, but that's how we get to comorbidities. Go back to your OASIS guidance manual and look at what they're saying, because those are some of the that is some of the information in the definition of primary diagnosis group assignment, and inclusion or exclusion as relevancy of comorbidities for comorbidity adjustments is exactly where ADRs are going to be picking it up and going to be using as their justification if they're looking for a denial.
That was a very thorough answer, and I'm pretty sure the folks that sign on here love that kind of stuff. So thank you for that answer.
And you get a tiny bit energized talking about that, just a little bit.
And Cindy, yeah. that leads us to clickitis, right? I want to take this moment to mention that all diagnoses that are listed on your OASIS or in your documentation does not need a goal. Every one of the diagnoses do not have to have a goal if they occur, and I know that that's one of those big myths that are out there. So I never miss an opportunity to say that one. Do I, Cindy?
No, because if you're really going to focus in on what you're supposed to be using those spots for comorbidities, then you follow by logic. If it is something that's going to be actively treated, then yeah, a goal for that makes sense. But we see this OCD that has, everything listed forever that they've ever had, and then, oh my gosh, I need to have goals and interventions for every single thing that was ever listed, and then we end up with a plan of care that is gigantic, and then we go, oh well, okay, we covered all our bases. But I think the downstream compliance risk is, if you put all that on the plan of care, then you're expected to actually do all that. And so that's where we see issues with the state surveyor, who shows up and says, well, you didn't do most of what's on this plan. And a clinician who says, well, I wasn't going to anyway. They didn't need me to do a lot of diabetic teaching. They already knew it. They've had diabetes for 15 years. Okay, then why did you put it on the plan? So I think all of those pieces, all of this I have to just becomes this beast of a care plan that we need to step back and say, okay, I know what I need to do to be compliant. Let's make this very patient specific and let's focus on what we're actually going to do with them over the course of care. And if we have to change it later, if we thought this was okay, Dee, and okay, his diabetes, he's had it forever, everything is good, I'm only going to keep an eye on it, I'm not going to make it a cornerstone of my care plan. If 2 weeks into this, something happens and his blood sugars all of a sudden go all wonky and I'm going to have to get way more involved in the diabetes, I can just get orders and change my care plan, correct?
Yeah, so here's what I want to say, because I threw out an acronym that had a lot of letters that were incorrect. So I refer you to your current copy of the official guidelines for coding and reporting, fiscal year 2021. And if you go to page 112 of 126 of that Decision Health publication, you will see section 2, selection of principal diagnoses, and then you can go on further under that and you'll see section 3 of reporting of additional diagnoses. But the actual acronym is the Uniform Hospital Discharge Data Set, or UHDDS. Okay, and so what we know about the application of these definitions of principal and secondary or additional diagnoses or comorbid diagnoses has been expanded to include all non-outpatient settings: acute care, short-term care, long-term care, psychiatric hospitals, home health agencies, rehab facilities, and nursing homes. Okay, and they also apply to hospice services. So if you understand that and you know that these are the definitions, the UHDDS definitions for primary and secondary, you have very clear guidance that is also referenced in the OASIS coding, the OASIS D guidance manual under these specific M items, primary and additional diagnoses. So I just wanted to get that right for people now that I was able to get to the right page in my official guidelines. So I try to always keep my references on hand. It doesn't always work, but I try really hard.
And you guys, that Dee saying that actually reminded me to make sure and put up their contact information. So if you have any questions about any of the answers that we gave during this session, or if you have any additional questions that maybe spring up later as a result of our discussions today, please feel free to use their email addresses and reach out to them. And I'm sure that they'll return that email in at least a month. At the very long, no, I'm kidding. They'll return it very quickly. And I have another question. Indeed, I think this might get de-energized again, Cindy. So I'm taking a stab at it, but it has to do with face-to-face. Huzzah! The crowd goes crazy. Okay,
that's my favorite. I love this question.
I know it is. Same situation. Okay, we received orders from a community doctor wound clinic, but he will not be signing the plan of care. The PCP will. He will, however, be sending and signing orders for just the wound care. Since the doctor from the wound clinic is not signing the plan of care, even though he may sign some of the verbal orders, do we still need to get a face-to-face from the PCP who is signing the plan of care?
Well, technically what I would say is that's your best option. That is your absolute best option, because there's a lot of other things that are going to be on the plan of care. Now, very clear guidance in chapter 7, section 30.5.1 that talks about who can do the face-to-face and when it's not done by the responsible physician. It has to be documented a certain way on the plan of care above the signature of the responsible physician's signature and dated. So I would say here's the quickest way: have the PCP do the face-to-face. Make sure that that visit specifically talks about the reasons why home care is important. Make sure that wound care physician who will be you will be taking orders from is listed as also a physician who will be receiving you'll be getting orders from specific to the wound care, and that's listed on your plan of care above the signature of the responsible physician. That's the best way to do it. But again, just like we dive through this idea about comorbidity, you got to dig into the regulations, and so there's really great information information about who can do the face-to-face, when it's not the referring physician, how it is dated and reported, and what that other physician does. Like a hospitalist might do a great face-to-face about continuing care being followed by the primary care after they leave acute care, right? And they have all those, they have many of the elements that are required for the face-to-face. Well, they have to be identified and documented a certain way with the dating of what that face-to-face document is. And that's clearly laid out in the language. There's also a great resource, since there is no exact form we have to use for face-to-face, while we're talking about that, Cindy and Sherry. And if you're not familiar with Medicare Learning Network, just go on Google and search Medicare Learning Network SE 1836. Shoot, I drew a blank. 1436. It's basically the Medicare Learning Network resource for completion of the face-to-face. It summarizes Chapter 7, and it also gives you great examples. I think it's 1436. Okay, S as in Sam, E as in Edward, 1436. And it shows you what is a good face-to-face and what is an insufficient face-to-face. Once again, as we come back into audits and we see auditing starting to pick back up, even though we still have the pandemic and we have the waivers, we have release of the audit animals, and they come back to, you know, where there's chum in the water, and there's always chum in the water related to face-to-face. And so you need to know your elements of face-to-face inside and out, how to document it, how to ensure, not just label a document as a face-to-face document, but does it speak to the elements? Because we have up to 90 days before the start of care date and 30 days after. So did we get the orders from the wound care, to circle back, Cindy and Sherry? Yes, we did. So we can start the treatment because we have valid orders to open care in home care. We go in, do the comprehensive assessment, establish those eligibility requirements, look at that face-to-face, which is very focused on the wound. Oh, okay, maybe that's not great. We schedule with the primary care. We say after we do the comprehensive assessment, within those 30 days after, and we get a complete H&P from the primary care, who is the responsible physician that we've already identified, and make sure that that visit note speaks to why they are receiving home care and that they're taking orders from the wound care physician. And now we have a great, robust face-to-face document, and we will not get this kicked out at the eligibility level. You can provide the best care, and you can have the best defensible documentation that is skilled, reasonable, and necessary for every clinical discipline in the house. But if you fail to meet eligibility requirements to start care, the entire case is subject to denial. One of the top reasons that happens in home care is due to insufficient and invalid face-to-face documentation. And that is one of your eligibility requirements. So,
okay, so we have a question, Dee, and I'm going to jump in there on the face-to-face that came in through the chat box. Can you clarify that vitals are not needed on the face-to-face visit, if they are or if they aren't? They're having a PCR Palmetto reviewer non-affirm. This must be someone who's in an RCD, because the vitals are missing.
On the face-to-face visit from the physician?
Yeah.
Or the non-physician provider? You know, there have been a lot of quirky things. I would question that. And so without going out and say a definitive yes or no, if you would like to email me, I will do research for you and I will find that out. Kornetti at Value Beyond the Visit, because, you know, the RCD, you know, you've got to dig into that document and what are the essentials. So I would go to my seminal elements. I would go to the Medicare Learning 1436. I would go back to section 30.5.1, I believe, which is the face-to-face encounter. And I would make sure that I read that word for word, because there's a lot of stuff in there, right, that you have to be particular to. So, you know, and this is not unlike Palmetto, right? So I'm not going to give you a definitive yet, but if you would like me to do some research and follow back up with you, I would be more than happy to do that if you email me. Cindy, we've never seen that happen before, have we, with Palmetto, where let's talk about goals. What do we know sometimes that the fiscal intermediaries have done? Heck, with not paying and denying services because patients didn't improve, or they didn't have short and long-term goals. I mean, you want to jump in on this one?
Well, I mean, I think sometimes it's an important piece to go back and research further, because it seems at face value, no, that doesn't make sense to say it's just off of vitals. But we'd want to check. We never want to shoot from the hip and potentially give misinformation. But we also know that at times you can hit a reviewer that isn't really following the rules, is picking things for whatever reason that they think is accurate that turn out not to be. And I think, it's tough sometimes to stand up and try to push back on that. Some folks just say, well, if I just roll over, then they'll go away and leave me alone. But it seems that if they pick on something like the infamous, the patient walked further than 150 feet, therefore we're not paying for this anymore. People just kind of agreeing and not checking and not challenging just allows that kind of stuff to continue. So we always welcome when people come to us with, this is what I'm seeing, or this is what someone's trying to tell me. So we can assist whenever possible to research that, to figure out if that's an accurate thing, or to point you in a direction to be able to come back and say, actually, no, you can't do it for that reason, and here's the resource.
Yeah, and think about it. I mean, the fiscal intermediaries on CMS's behalf were denying claims because the patients weren't improving, right? And that brought about the whole Jimmo v. Sebelius case, because that part of the benefit was absolutely being denied, and there was no comments about was the service skilled, reasonable, and necessary to maintain or to stabilize a patient. So we have, seminal documents where sometimes the reading or the interpretation is such. So that does not jump out to me, but I'd have to look at what that face-to-face physician visit note must include. So before I could answer the asker's question, I would have to dig a little deeper and, put out my bat signal and check in with the people I know to make sure that I haven't missed any resources. So I'm hoping that you'll reach out to me by email, whoever asked that question, because I totally dig myth busting on things like this.
Okay, on that note, our last question, drum roll please, is another face-to-face question. Okay, here's the scenario, and the question is, can a radiology note signed off by an MD, accompanied by an MD note from the rehab facility, support a primary need for home health? I know you need the scenario. Patient was hospitalized and subsequently sent to rehab. While in rehab, a staff member was changing the patient's diaper and accidentally rolled the patient off the bed, where she hit the floor and fractured her shoulder. Patient was taken for x-ray. So that's where they have the radiology report from 317 signed by the MD, which documents an acute minimally displaced fracture of the greater tuberosity of the right humerus. The next MD note from the facility, dated 4/2, documents a right arm fracture, patient to follow up with ortho, right arm in a sling. Patient did not follow up with the ortho until outside the face-to-face time frame. So that info is all they have to go on. Dee?
Okay. So Cindy knows this answer. And the answer is, can a radiology note signed off by an MD, an x-ray, signed off with an impression signed by a physician, can it suffice as the diagnosis? And what I understand the x-ray report said, that was signed by the physician, or you had the radiologist, who is a physician, give you their impression, says that it's an acute minimally displaced fracture of the greater tuberosity of the right humerus, which is a right arm fracture. It's a much more specific diagnosis. And the answer is yes, because the radiologist gave you that. Now, if all you got was the x-ray and you didn't have the impression and you didn't have the physician's signature of what that interpretation of that x-ray was, no, you cannot do that. You cannot code from a lab value. You cannot code from a medication list. You cannot code from a specialized test. You have to have the physician's documentation of it. And here you do. So would I code an unspecified a fracture of the right upper arm, unspecified, or would I code minimally displaced fracture of the greater tuberosity of the right humerus? And I would say I would code the latter, because the minimally displaced greater tuberosity, that is sufficient documentation. And even if you got that on the face-to-face, you know what's driving the care, right? You have that order coming from the hospital. So absolutely, I think that that's sufficient, and good job in getting the physician documentation. Part of it isn't so much in understanding or having the documentation there for you. Ultimately, it's having intake people that know what documentation to look for, right? You can't just grab 75 pages of therapy notes from the hospital and think you've got what you need. You might only need 15, but they have to include key elements that are integral to it, to making sure you have diagnoses, and making sure that you can hit all those marks to get the primary reason, if it's the face-to-face, and those comorbidities. And so having very educated and informed intake staff is essential in PDGM, with 2 of those 4 pillars coming from coding of primary diagnosis group and comorbidities to potentially get a comorbidity adjustment. So the answer is, I would feel great if I got that documentation. Good question. Great job.
And the face-to-face will continue to deliver additional questions as we go through life. And I know
it has for years,
that,
since it's been around. It's never gotten
exactly.
It's never gotten resolved, and it's always one of the top 5 reasons why denials happen in our industry.
Exactly. I want to, as we conclude, I want to thank everybody for joining us today on this session, and thank myself for making sure the recording happens so that we can send this out to you guys. And I wanted to also mention again that we are in a comment period for the 2022 TPS proposed rule for home health. There are many items in that rule that need to be addressed by everyone, not just you guys as leaders of your agency, but also your staff. And patient comments and patient letters are awesome for the comment period. The CMS has to address each question that they receive, and the more, the better. We are also going to be doing podcasts. Cindy has already done a couple podcasts with me about the proposed rule, and we're going to be putting out a bunch of free podcasts regarding the proposed rule and items that we feel like we hope people address. And Cindy, I don't know if you want to take 2 seconds and say what one of your hot button issues is on the proposed rule, but go ahead.
Well, we talked a little bit in the one we already did about value-based purchasing. I think we're going to have to talk about that one a little bit more in terms of what that means, what it means or what it shouldn't mean. I think the other piece, and we touched on it briefly here today, is the different than expected functional scores and how we make sure that what we have is defensible in our record, so no one looks at that and accuses you of gaming. But to make sure that we are adequately capturing those functional items. You would think, you know, those questions have been unchanged in 20 years, so that their predictive modeling of basically a third between low, medium, and high should have been pretty close to on. The fact that it wasn't is disconcerting. So we need to talk about that a little bit more as well.
That's awesome. My personal hot button issue on the proposed rule is how they're parsing out the abilities of the OT in home health. Give them full rights. Now, today, I'm going to be campaigning for that. Don't just keep metering out pieces of the rule and making it more confusing than it has to be. Dee, do you have a specific one that's on your radar?
No, I don't. I just have enjoyed the heck out of answering these questions today and digging down the rabbit hole for references. I mean, that's the one thing you get with Kornetti and Krafft is we are going to go to the resources and we are going to be able to use those to verify, you know, any position, any decision, any recommendation we make. So thanks for that opportunity today.
Oh, and before we close it, Sherry, for people who were on the call last month, we did promise updated pictures of ourselves. So I think these look much better than the ones people were subjected to the last several of these we've done. So thank you for getting those on the final slide.
It was a last minute thing. I feel pretty good about that, Cindy. So join us at our next Q&A. It will be in September. And if we go by our pattern, it will be somewhere either the 16th or the 23rd. But those of you that are on this call probably follow our newsletter, and we will be announcing that finally to give you guys the time to prepare your questions. And please take a moment and submit those questions ahead of these sessions because it makes it much more interactive and much more timely. Thanks again for joining us. Until next time.